All right, we've got a pretty good contingent, and so I will turn it over to Dr. Ryan Stringer, who will present for us today.
Thank you very much. When I was thinking about a topic to launch our fellow lecture series, this is an area that I really knew nothing about. Radiation therapy was kind of this nebulous thing that patients get sent to and that we deal with some of the complications of, but not something that I knew the details and nuances of why it was offered. And so without further ado, I will start out. So objectives today to briefly review the principles of radiation therapy, look into the indications for the various applications in our oncology patient population, some emergent indications for referral that we may encounter or may have been receiving patients on the other end of, and then discuss some of the dosing definitions and protocols and how that changes some of our advocacy efforts when we are working with patients through the disease process and journey of their diagnosis. And then a brief discussion of toxicities and side effects as a review. I don't have any financial disclosures. The only disclosure that I have is that, again, I've not had any extensive training or knowledge of radiation therapy beforehand. And so I certainly invite those who are far more senior to myself in this field who have had more experience and exposure as well to shed some additional light on what we're discussing today. So as an introduction, radiation therapy is a very common therapy for our oncology patients. It's been around since the early 1900s when therapeutic dosing was determined by radiologists pointing x-rays at their own arms to determine a sunburn effect for dosing, and that was an acceptable level of dose to be administered for the early cancer treatments. And so we've come a long way since that time. More than 60% of our cancer patients will have some type of radiation treatment. And often this is, as many oncology interventions are delineated, those of curative intent and those of palliative intent. So for curative, usually that's going to be more limited to well-defined tumors, sometimes residual disease after resection, and then in conjunction with chemotherapy, which is often a sensitizer for the cancers that we're treating to make the radiation therapy more effective. And then from a palliative approach, which is where the majority of the lecture is going to be at towards the end, is on symptom management and then also improving functional status for the patient as well. So what is radiation therapy? I mean, we know that this is probably not the pictures that we think of when we're discussing radiation therapy, but kind of questions are some of our patients who may not really understand what we are talking about. It can be a somewhat scary concept. So I hope to provide a framework to provide some additional information for our patients when we see them. So this is kind of taking me back to high school or earlier physics days. But the electromagnetic spectrum, we are primarily looking at the energy that's being delivered in the realm of X-rays, some degree in gamma rays from radioactive elements, but primarily in the X-ray territory for energy being delivered. Now, this works in a couple of different mechanisms. So ionizing radiation delivered to a targeted area within a tumor is going to deliver energy, and it does not disrupt the DNA in and of itself. It creates oxygen-free radicals within the cells that then destroy and manipulate the DNA, which has implications for oxygenation of the tissue and the reasons why that might be tried to be optimized. So even things like anemia can have implications for the effectiveness for radiation therapy. Sometimes we'll get into gamma rays with certain treatment modalities, but primarily when we're thinking about palliative intent, X-ray radiation is going to be the primary source. There is some increased interest in proton therapy and charged atoms using the linear, different kinds of machines, but that's a fairly new area of research and not as significantly, there's not as much knowledge or information based, and it seems to be more an area that's under development. So an external beam linear accelerator is what we will see in our radiation departments often, or radiation therapy departments. And this is what that looks like on the top. So it has a rotating axis to be able to get several different axes of delivered energy into the tumor, hopefully attempting to spare some of the normal tissue. Like I was mentioning, proton therapy with a particle accelerator, it is a very, very large machine. They have one in Beaumont on the east side of the state and had a price tag of $40 million. So I think that there are a handful of these around the country and a lot of exciting interest. The idea behind proton therapy is that if you have a proton from a particle accelerator, then it destroys the tissue at the end of its trajectory and spares some of the tissue as it's passing through the body. Again, there's some implications for decreasing symptom management, but I think that as far as the survivability and prognosis standpoint, it's still being researched. And then there's internal therapy or brachytherapy, which can be an intraoperative administration or sometimes implantable, especially those in the pelvic cancers and the GYN and GU applications. So moving on to how do we end up writing a referral, it's probably not going to be us more than medical oncologists, but it's really a multidisciplinary team like several areas of medicine. So the radiation oncology team is really not just the radiation oncologist. They work in conjunction with the medical physicist and dosimetrist to come up with the protocols, and then radiation therapist actually delivers the therapy to the patients. And then often a radiation oncology nurse is dedicated to do the coordination of care and getting people moved through the department. So what is involved in the planning? It's a pretty involved process. So targeting the area of treatment and what to avoid, which is called contouring. Usually that's done with a simulation trial with a dedicated imaging down in the radiation oncology department. Often it can be used in conjunction with some of the imaging that's already available that had diagnosed the cancer to begin with. But usually it is a dedicated piece of equipment that's in the department so that the consistency and delivery of therapy is the same every time. Often patients have to be immobilized in some of these molds and devices to make sure that they are not moving and that the radiation is being delivered only to the area that it needs to be every single time, because these are very high doses of radiation. So the medical physicist and dosimetrist, they assist with determining the dose delivery. How much energy is going to be needed? What trajectory are we going to be putting the radiation through? And what kind of repeat dosing is going to be needed to deliver the total maximum dose into the tissue? And so they work with the radiation oncologist who eventually approves the plan. There's multiple safety checks and quality assurance before this is even delivered. So this all takes an extraordinary amount of time for a lot of patients, especially when we're looking towards cure. So sometimes in the realm of several weeks for that to actually be done. So it's a lot more difficult than just making a referral and sending them to the office tomorrow or the day after. So dosing itself gets a little bit more complicated. So it's not just a dose like you would think of as a dose of antibiotics or pain medications. This is described in terms of fractioning. So the total radiation delivered over the course of the treatment is usually divided into fractions or doses delivered in each session that the patient ends up experiencing. It is measured in gray. And just to give you guys a little bit of an understanding of what kind of radiation dose that we are actually discussing, 1 gray is 100 rads, and a CT abdomen pelvis is about 1 rad. So we are on several fold higher for the radiation that's actually being delivered. But this is all targeted towards a very specific area in a beam that is sub-millimeter length thick. And so really delivering that in a very, very accurate area and not all over the body. Curative doses are often in the range of 50 to 80 gray on one resource that I looked at, and then palliative treatments being less in the 7 to 35 gray and less than 10 fractions. So why does fractioning work? Well, there's a principle of we want to damage the DNA of the cancer cells and then try and spare the healthy cells. That is often not avoidable. And so we take advantage of the fact that the healthy cells have the normal repair mechanisms in place and cancer cells really don't. And so if we can continue to insult the cancer cells while allowing some regeneration for those that are normal in our body, then maybe we can get some traction on curing or even decreasing the disease burden. Higher dose fractions are seen in curative treatments, as we mentioned on the previous slide, and then palliative treatments, we try to limit those to smaller overall fractions. So there's a reference of the 4 R's of radiation oncology. So repair, these are the principles that can affect both healthy and tumor cells. So repairing the DNA that's already there, we hope that the normal cells can repair and repopulate. Often the cancer cells may repopulate as well. And then there's a redistribution phase where the cells are transitioning into different phases of growth and division, and they end up being more radiosensitive in some. So deliver a dose of radiation to the tumor, you end up killing some of the cells that are susceptible, and then being able to deliver a dose again at a later time allows you to, again, hit those cells that are a lot more susceptible in those different areas. And we talked about this a little bit before, but reoxygenation is also really important. So you get the inflammatory mediators, the swelling, so allowing oxygen to return to the tissue, making that a little bit more effective for subsequent treatments. So to make things a little bit more complicated even yet, these are all of the different types of radiation therapy that are offered at Trinity Health. This is off of their website and well beyond the scope of this lecture, but becomes a little bit more difficult to just simplify. But I thought was interesting in the different kinds of ways that radiation therapy can actually be delivered. So at this point in time, if I haven't lost you completely and you aren't drooling on yourselves and sleeping, we're going to get into a different part of the topic and talking more about the palliative applications.
I was just intrigued on that list of different types. How many are copyrighted names?
Yes, yes.
For those specific types of therapies there.
Yep, exactly. Yep. And you know, with the copyrights come usually considerable expense along with that too.
I'm sure that they're more expensive.
So Robert Parker is someone that I discovered in preparing for this lecture as what seems to have been a pioneer in the radiation oncology world. And in his article from 1964, he had written, when the initial objective of radiation therapy is palliation, new ground rules must be applied. Possible serious complications or even slowly self-limiting adverse effects of treatment are no longer acceptable. Overall treatment time must be short, costs must be minimized, and convenience of treatment must be considered. I think it's a really insightful and appropriate statement, but really amazing for the newness of the field and at the time of the 1960s, when this is still all being developed, and there's a lot of excitement over the advances that were being made. So we're going to get into some of the reasons that we might use radiation therapy for palliation of symptoms, one of which is bleeding. So symptomatic bleeding from lung cancers in terms of hemoptysis, the gastrointestinal tract, or even genitourinary as well, that can sometimes have complications of obstruction as well. You can get some improved control in about 1 to 2 days after treatment is delivered. Of course, one of the limitations of this is going to be the hemodynamic stability of moving to the radiation therapy department. If someone has not already been optimized with some of the preparations, then you have to take the time to do the contouring, the preparation, the dosing, and then the delivery. So that can be sometimes a limiting factor, but bleeding is something that could be potentially affected from this standpoint. And looking into obstruction, so as we mentioned before, the lung cancers or even head and neck cancers and upper airway are burdened by symptoms of dysphagia, dyspnea, hemoptysis, chest pain, difficulty with swallowing nutrition, some nerve injuries or brachial plexopathy or vascular airway compression. So radiation therapy can be delivered, ultimately attempting to shrink the tumor and control some of the symptoms in that sense. Can be delivered for GI malignancies, both in the intestine and in the rectum for obstruction purposes. The thing about delivery in these areas is that you get a little bit more risk of the mucosal injury, both in the gastrointestinal tract as well as in the upper airway. And so some of those side effects can be pretty burdensome. This picture is showing what we might find with the radiation esophagitis, symptoms that we are may see fairly commonly. For GYN and urogenital cancers, again, for bleeding, pain, and then obstruction, these can be done in external beam therapy, but then as we mentioned before, the brachytherapy or implantable therapy. So either inserting some kind of radioactive substance for a defined period of time, and then having that removed. That can be done in a very quick fashion, intraoperatively in the tumor site, like for a breast tumor resection. Or even implantable seeds that can be done. One that I saw was in prostate and uterine cancer. Then moving on to breast cancers, ulcerations, bleeding, edema, these are all things that can potentially be palliated by radiation therapy involvement. And moving on to some of our radiation oncology emergencies, malignant spinal cord compression. So we think about a cauda equina type syndrome, not necessarily from a bulging disc, but a malignant tumor that's eroded through, or even a metastatic disease that has now invaded into the spinal canal. So we see patients that have new neurologic deficits, sudden loss of continence, inability to walk, life-limiting disease burden, and imaging is obtained. This is a call to several different people, so not just radiation oncology, but also neurosurgery, typically, or a spine surgeon. The reasons why we want to consult both is that we need to have an estimation of what kind of likelihood the patient has to survive surgery. That is still the standard of care, is to debulk the area that is being compressed and then follow that up with radiation oncology. But oftentimes the patient doesn't have the ability to go through surgery, either because of functional status or comorbidities. And that does not necessarily mean nothing can be done. We can still involve radiation oncology and mobilize that treatment fairly quickly to help to shrink some of the tumor burden, and hopefully within that 24 to 48-hour window, salvage some of the neurologic deficits that were there. Our overall goal is to try and stop the progression, reverse the symptoms. And then, of course, we're giving dexamethasone fairly early on, and then also throughout the treatment course, that when radiation therapy is delivered, then that medication allows us to avoid some of the swelling and further compression and inflammation. Another reason that we might see a more urgent referral that can speed up the process is in brain disease, either with metastatic disease or primary tumors that have associated edema. So symptoms of seizures and headache, personality changes, speech changes, peripheral neuropathies, and vision. These are reasons that we might need to involve radiation oncology a lot more quickly. Still having discussions with neurosurgery, still trying to make sure that we provide the opportunity for natural surgical resection, but often radiation therapy is involved in this as well. And that's where that CyberKnife, one of the branded treatments, end up coming into play, is that they can have a very precise delivery to a tumor, especially if it is well-defined or a single lesion. Post-surgically, or even before that, if the patient's functional status does not allow. There is some description of whole brain radiation. The guidelines that I was taking a look at didn't really seem to support that idea all that strongly. It depends on what the patient's prognosis is and whether or not there is some hope for a cure or some hope that radiation therapy would be effective in a radiosensitive tumor. But most of the time, there's really a lack of survival benefit. So patients are not living longer. We may be able to help stop spread of the tumors based on imaging, but it's not going to provide much more length of life. And then we have implications of prolonged symptoms like fatigue, nausea, and cognitive decline.
And I'm going to interrupt real quick. Just a question. In your research, did you see any difference between primary CNS tumors and METs and what they decided to do, like radiosurgery versus whole brain radiation?
I did not see that delineation specifically. Okay. Yeah. Have you had discussions with any?
I haven't really looked into it myself. It just seems like more metastatic disease. There's a trend more towards that whole brain versus that primary.
Yeah.
I see much more of that radiosurgery.
Yeah. The only thing that I did see is that if there are multiple lesions, then sometimes that can be reached for to help prevent spread of additional lesions coming up. But the discussion that I saw was really more of the implications of is it actually providing that benefit? Again, radiographically, we can try to prevent the spread, but then we're still irradiating the entire brain and having all those implications of the side effects.
From a anecdotal totally non-scientific perspective. Over the last several years, whether it be patients or acquaintances and friends that had had metastatic lesions. One was from breast, another was from melanoma. No, not breast, lung, 2 from lung, and there were 3 of them. And they all had them spot welded. There was no whole brain. They just, when something developed, they go to, they zap that. They go on with the rest of, their lives and treatments, and something else will pop up and they go and they zap that. And, yeah, I just call it spot welding. I'm sure there's a more scientific name for it, but that's what they were doing.
So maybe there's a trend away from whole brain in general.
Yeah.
It seems to be. There are some guidelines more specific and depending on what type of tumor that it is, but it seems to be that the whole brain radiation is just, devastating to have that kind of an insult to every area of our being. And so they talk about avoiding the hippocampus, and then if whole brain radiation is delivered, I think one of the recommended guidelines was starting Namenda early on for the protective effects. There is a graded prognostic assessment tool that can help to guide some of the implications of survival and what decisions might be made regarding radiation therapy that is available as well. And one of the final oncology emergencies that we might see, and this is probably more likely to show up maybe in the palliative practice as we go along in the treatment process, of vascular obstruction and specifically SBC syndrome with regards to either thyroid or lung tumors. So in this, we might see cyanosis or edema of the face, arms, maybe some voice changes, or even in the later stages of obstruction, some brain edema causing neurologic deficits. After radiation therapy, one resource that I looked at referenced that after 72 hours, you can start seeing some relief, with about 50% having resolution of symptoms for a lung cancer diagnosis. So edema of the face, engorgement of the blood vessels over the chest, because you have to get collateral flow back through the heart. It depends on where that obstruction is relative to the esophagus vein. But one interesting sign that I also saw, which was actually more for goiters, but can also be seen in SBC syndrome, is something called the Pemberton sign, where they raise their arms up and then obstruct that thoracic inlet and get facial flushing as well. And that can be something that I don't know the data as far as sensitivity and specificity, but I would think that if we saw this, that would probably prompt, if we didn't already know that there was a large tumor compressing, then certainly an aggressive workup to figure that out and try and get people into radiation oncology. This is an article that I thought was very interesting. So top 10 tips palliative care clinicians should know about radiation oncology. One of those was the most common indications for palliative radiation therapy are symptomatic bone, vertebral, and brain metastatic disease. And this, they cited that symptom relief usually begins about 4 to 6 weeks after the final radiation treatment session. So depending upon why we're using that, for things like bleeding, for things like the vascular obstruction, you can start to see some of that improvement right away, even for some of the CNS tumors when they're causing nerve impingement. Might see some benefit a lot earlier. And certainly we can see a slowing of the progression, but usually from a pain standpoint, symptom relief is going to be in the realm of weeks later. Which brings me to one of the larger indications for our referral to palliative radiation is spinal bony metastatic disease. There's a high propensity for metastatic burden within the spine from several different types of cancers. They are delineated by whether or not it's complicated or uncomplicated. So a single tumor that is well defined into the cortex of the bone can often be treated with a single dose of radiation. It's as effective pain relief as multi-dose or longer courses. There are implications for retreatment up to 20%, but when we're thinking about multi-dose radiation therapy, that almost seems like retreatment in and of itself. The benefits and risks seem to weigh just giving them the single dose and then allowing them to move on with their lives. For complicated tumors, that is where we rely more heavily on some of the new protocols and research that's coming out. So spinal cord compression, if there's tumor that actually extends beyond the cortex of the bone, or in bony metastatic disease that's in weight-bearing structures that are not within the spine that also has complicated dosing that would be different than just giving the single dose being delivered. Those are usually fractions of several treatments, and then the retreatment is lower. So when fraction treatment is provided for these indications, the retreatment rate is lower, but not nothing. So the recurrence of disease or recurrence of symptoms, often you will need to retreat. So there was a trend and shift about a decade ago, from what I could tell, with articles starting to come out, looking into why radiation therapy is being delivered, and does it make sense that we're delivering several rounds and several doses for all of our patients?
This is totally irrelevant, except that the last lecture we had on radiation therapy was probably 10 years ago.
Oh, funny.
And it was Dr. David Howell that did that.
Well, there you go. Dr. Howell, if he somehow ends up listening to this, thank you for your contribution. So single fraction radiation therapy versus multi-fraction radiation therapy for painful vertebral bone metastatic disease. In this article, there was no statistically significant difference in pain relief or freedom from narcotic use at 3 months. There were differences in toxicity, and specifically GI toxicity, which was half or a little less than half of that for the multi-fraction regimen seen at 3 months, and lower toxicities in general were seen with single fraction. Again, looking at the bottom, there is a higher retreatment rate when we're looking at the overall burden of going to the radiation oncology department. It seems to favor just having the patients come once. So that led to some of the recommendations from societies like Choosing Wisely in many areas of medicine, but the American Society for Radiation Oncology, among several of their recommendations, I bolded here, don't routinely use extended fractionation schemes for palliation of bone metastases. And then the governing body, ASTRO, for the American Society of Radiation Oncology, they came out with their guideline recommendations. And among several, the most salient to this discussion is for peripheral bony metastatic disease with pain, single fraction is equivalent, provides equivalent relief for pain as compared to the multi-fraction dosing. Same thing with uncomplicated spinal mets. And then a discussion on the limiting long-term side effects of the single fraction. So we're giving these massive doses of radiation all at the same time. Does that increase the risk of having some kind of negative side effects, either from acute toxicity or latent toxicity? And the answer was really no, that those are well tolerated and really well supported. So this discussion extends beyond the United States, and the study looking at Canadian radiation oncologists. They mentioned that despite randomized trials showing similar results for single compared to multi-fractionated radiotherapy, the majority of radiation oncologists still advocate for 5 fractions. There's a difference between the US and Canada. They were kind of on a 5-fraction regimen, whereas the US was a lot more, but even so, they acknowledged, interestingly, the reasons why the results of randomized studies on bone mets have no impact on the patterns of practice are worth exploring, which I would agree. If the evidence is not supporting the use of continued and multi-fraction treatments for pain relief, then why aren't the practice patterns really changing? So this is a study that came out of the University of Michigan that I thought was very interesting. So we see kind of a really slow trend. These guideline recommendations are coming out in the 2012 to 2014 to 2017 range. We see maybe a little bit of a shift in their institution with a decreased number of treatment fractions per course of radiation. And then suddenly COVID-19 hits in 2020. And now we're trying to keep people out of the hospital, having resource utilization, staffing crunches, and we see this precipitous drop in radiation being delivered. Now, was this intentional? Was there some kind of a confounding variable? I guess that very well could be possible. But I thought that this was interesting and pushing at least the University of Michigan's institution into a realm of let's be conservators of the resources that we have. Let's try to keep people out of the hospital if it's not necessary. And that accelerated the adaptation of the recommended guidelines.
And not to be too cynical, but or follow the science.
Right. Yeah. Right. Exactly.
Which is always perplexing to me. I mean, I would, I'm looking at these early articles that are coming out of 2016, 2017, and some going back to 2013. We've known for a decade that this is what the science says.
Right.
And I can clearly remember calling radiation oncology to tell them, I want single fraction.
Right.
And having this, not argument, but this discussion, sending them their articles from their journals, validating that this is what works and this is what we want for our patients.
Yeah.
Breaking that pattern, and you know, we can go into a lot of other areas of medicine as well, where behavior is hard to change despite science.
Right. Absolutely.
Fascinating to me.
Yep. Same thing goes true with choosing wisely recommendations for traumatic brain injury and CT imaging and chest X-rays for pediatrics and antibiotics for bronchiolitis and things like that. Adaptation is very slow. One of the things I think that complicates this is that there are over 100 fractionation schemes worldwide, and one study that referenced this. This is just an example of the different ways that radiation might be delivered from one article that allows some variation and guidelines that are being provided, but there is still a wide range of clinical judgment on what kind of treatments are going to be delivered, and depending on the patient's functional status, how that has implications for what is ultimately delivered for them. So understandably, if there's a lot of variation in practice pattern throughout the country and even throughout the world, then we may see some difference, and maybe there's not really the similar way that if you go to one institution, you're going to get the same thing. So it makes it complicated to change the standard culture everywhere. So maybe one of the discussions that we should be having is we should not receive radiation therapy as well. And there are several factors that may be relevant. So if death is imminent, the patients are probably going to be passing within that 30 to 45 day window where they're not going to get the benefit from the radiation therapy being delivered, because we're at that 4 to 6 week, depending on what the symptoms are that are trying to be alleviated with the radiation therapy. If there's multiple progressive symptoms and radiation is only going to be able to target really one of them, then that's probably not going to be the high yield way for a patient to spend their last days. There's implications of transportation or resources in getting to the hospital, family or caregiver support and burden. And then what is the side effects? As we often have discussions with any of these therapies for our oncology patients, what are we expecting to see out of the treatment, and what potentially is this treatment going to take away from you? And that brings us to a discussion of some of the side effects, which we are all fairly well acquainted with in different contexts, probably more so in the outpatient setting than inpatient. Let's start with the discussion. So these are usually divided by acute side effects, lasting up to 3 months in time. Oftentimes at the radiation therapy, when it's being delivered, and not necessarily just in palliative regimens, but across the board, once we get towards the end of treatment, that's when some of the side effects really start stacking. We get more and more damage to the normal healthy tissue, and that's when the side effects will start to become more burdensome. And so often those will resolve 4 to 6 weeks later. We provide some of that supportive care. Some of the latent side effects, we think about our cancers. So from a survivability standpoint, if cure is the intent or cure actually has been achieved, then what is radiation therapy doing as far as risk for development of additional cancers? So hematologic cancers, a lot of those radiologists who were basing dosing upon the sunburn effect on their own skin, a lot of them ended up with leukemia. And then 10 years out from radiation therapy is when we start to see more of an increase in solid tumor recurrence or new solid tumors as a result of the radiation. You can also get fibrosis that develops, especially in the lungs. Pulmonary fibrosis is one that is particularly delayed because it starts to change some of the cells towards fibroblasts, and then also a vascular disease like coronary artery disease. And so what we do well and what we do best is often providing some of that supportive care. So several different medication types, as Dr. Mulder likes to say, is a deep bag of tricks and has yet to reach the bottom. We're reaching down into there for some of these ways to support our patients through these side effects of radiation, and providing that reassurance that typically once radiation has ended, that side effects can wane after about those 4 to 6 weeks. And one of the discussions I thought was interesting is what about hospice? So less than 3% of hospice patients receive radiation therapy, which is understandable. By nature of hospice, we're not pursuing curative interventions, but from the standpoint of palliation of symptoms, does it make sense for us to develop relationships with a radiation oncology department and have some of those conversations about, can we do single fraction treatments? What's the cost of that? What are the barriers to transportation? Is there already a perceived lack of willingness to pursue single dose treatments? And that conversation barrier has just been put up, and we need to start having more of those discussions. And then looking into more of the financial implications and partnerships with different institutions. Can we provide this in a way that is going to be sustainable for the hospice, as well as provide that therapeutic benefit for the patient? So kind of the crux of all this is, how can we advocate for our patients in this way? And Dr. Mulder just kind of mentioned some of that, but when we're discussing the goals of treatment, how can we advocate for our patients and making sure that what they are desiring that we can try to achieve? Are we making sure that we are being a voice for our patients and discussing some of the ways in which radiation therapy can be delivered? Can we assist with prognostication? It's really not my comfort level, despite going through fellowship here, having the prognostication discussions from a standpoint of a tissue diagnosis and typically how long patients survive. But I think that we can at least have the voice in that conversation to ask, does this make sense? We can provide a more comprehensive assessment of the symptom burden and not necessarily just look at the tissue diagnosis and what patients have. And well, you have a certain type of cancer and we treat that with radiation therapy because that's what patients with this type of cancer get. But really asking the question of, what is the quality of life going to be like after this is delivered? And then having an assessment of the performance status right now, and then what is the implication of that after treatment. And then one area that I think that we're particularly good at is discussing and evaluating the social barriers to care. So can a patient that lives an hour and a half away from the hospital come back once a day for 5 or 6 weeks? That's going to be a pretty high burden for them. Are they going to be able to have caregivers that are also working to be able to bring them to the hospital? What are the financial implications of actually going through this kind of treatment? And does it make sense to shift the focus in a way that is a decreased burden altogether? And then also the physical implications of actually sitting in the radiation oncology department for a long period of time and what that does to their quality of life. You need to be careful with shifting this curve in our conversations, though. We want to avoid underutilization. So if we are looking at the radiation therapy delivered at the end of life, we don't want to shift so far away from that no one is getting therapy at all, which might be a marker that potentially there was some benefit that could have been achieved. If we are aggressive with shifting it one way or the other, we have to get into the portion of those who are given radiation therapy who end up dying at the end of life without actually achieving that benefit from therapy. But we want to make sure that we're not withholding this as a potential intervention. That really is a difficult thing that I think requires the input of everyone in the team that's taking care of the patients. And having those discussions of prognostication and expected outcomes, and not just basing it off of a traditional way that this is how we handle every patient with this type of cancer, but looking at the individual and tailoring it to their needs. And so this is where one of the graphs that I like to talk about with my patients, and I think is salient to the discussions that we have with our radiation oncology colleagues. We may have this discussion several times, not just that one phone call when we first meet the patient. It is the assessment over the course of the disease process. What I hope would be is that palliative care is getting involved very early on and can have some of those longer term goals of care, discussing what is this going to be like in weeks and months and years out into the future. And then as we start to progress towards closer to the end of life, that we can advocate more strongly for the palliative treatments as we start to exhaust some of the curative care, but still having those ongoing conversations and communication. So what new innovations are coming into the future? I think that dedicated palliative radiation oncology multidisciplinary teams, I'm seeing in some larger cancer institutions that they actually have a subset of radiation oncologists who are dedicated to palliative delivery. And that is brought about by a rapid response clinic. So you have someone that has a high disease burden or high symptom burden, then they can be plugged in, and then the protocols are able to be pushed through a little bit more quickly, and the preparations and the delivery, so that we're not 3 weeks out into the future, but can make things happen very quickly. And then also embedding palliative care within the tumor board discussions to provide that scope or that lens of what is it that makes sense for the patient. I think that some of the things that may come into the future are interactions with hospice teams. Is there a way to rapidly triage patients that have some of these symptom burdens and reduce the cost of therapy? Is this effective? And if it is, and helping to alleviate the pain, then instead of reaching just for escalating doses of opioids and the side effects that come from those, could we deliver a single dose of radiation and actually provide patients some of that burden? And then having formal palliative care training within radiation oncology fellowships is another thing that was mentioned in some of the things that I read. And I would even argue the opposite too, that having some of those discussions during our training with the radiation oncologists and maybe having some time with them to see the kind of things that are delivered and the challenges that they experience with these discussions with patients and forming that collaboration. Some additional resources for our practice is that the American Society for Radiation Oncology does have practice guidelines specific to different types of tumors. This is from their website that you can click on each of these little drop-down menus, and then they have a guideline that can be brought up for more detailed discussion if we're trying to advocate with our radiation oncology colleagues. And then there's 7 references also on fast facts that can provide an additional summary and overview. Here's some of the references that I went through, and without anything else, I'll open up the floor to any questions that you guys have.
Go ahead and stop share there. So one of the things I really would like to do here with our time, I noticed that there are several folks on the call right now who are, specifically engaged in the hospice realm. And I can tell you from a historical perspective that there's no question about what this was never considered to be an accessible therapy within the hospice realm. It was the burdens were too high. There were multi-fractions. The cost was an issue. So it was really never even looked at. And over the last 10, 15 years, when the single fraction issue came up, we started to say, maybe this would be something of value to our patients. But I just haven't personally seen that aggressively engaged. And so I would just be curious. I'll call a few up by name because I see up there Dr. Nasian, and I see that Dr. Gozman's on the call. And I think there are a few others that are working primarily in the hospice realm. What has been your personal experience within your agency relative to consideration for or coverage for radiation as a palliative measure for your patients? Any thoughts?
We've certainly done it a few times. I think it's more of a situation where we haven't been able to control pain and other, with other measures. But yeah, we've certainly done it in the couple of years that I've been with Faith Hospice.
Cool. Mike, I saw your face pop up there briefly.
Yeah, we've done it. We've done it a couple of times. The logistics can be challenging sometimes, like you said, with the communication. It was really striking Ryan, the time course for improvement. When we were talking about 4 to 6 weeks after the last fraction, are we? It's in that context, a patient who has a prognosis of 4 weeks or less probably is not going to benefit from pain relief from palliative radiation. Would you concur with that?
Right, that's most of what I was seeing, and I found it to be a little bit confusing and something that I wasn't able to sort out definitively. Is that there is some discussion of these symptoms like bleeding or obstruction or neurologic symptoms that are palliated very quickly, but in terms of pain relief, most expectations that I read were set in the several weeks time period. So yes, that is that discussion of, does it make sense in that last 4 weeks to be offering radiation therapy? And if someone's on hospice, then is that something that is an appropriate thing to be reaching for? I think that's a fair thing to discuss.
Yeah, that's because in the couple of times that I recall using it, the benefit was in bleeding, not so much in pain management. though the number of patients that we've had who've gotten radiation before coming to hospice and then get significant pain relief from that, I think that's probably more significant. That's consistent with what you're describing from your review. So very much appreciate that that info.
You know, I also think that we have become so comfortable with, and I think good at using opioids and steroids for cancer-related pain. And that we don't think of radiation as a first line. I'm not sure that we should think of it as a first line. But that, you know, those, as Mike said, you know, you've got those who are, you know, for bleeding. And I would say that the others that I've seen where medication has not been as successful are those obstructive cases, where the value there. So others' experiences in that, I just, even not in the hospice, but in the palliative realm, do you find yourselves thinking about this, or is it always sort of an afterthought when all else fails? I'd just be curious others' experiences.
One comment I had that I'd like to share is on my hospice rotation, I actually had several people who not necessarily did hospice initiate radiation, but the patient was declining, but really felt strongly that they wanted to finish their last couple of treatments. And so they were signing on to hospice with the intent of finishing up radiation because they very much didn't want to let go of those last few treatments, but also realized once they were done with the treatments that they did not really want to keep going back to the hospital. I was wondering your guys' experience on people signing on to hospice while undergoing radiation to finish up the last few treatments and then be done and follow a fully hospice focused mindset.
Great question. Thoughts?
I would kind of wonder at that point in time if it would be worth a discussion with the radiation oncologist, which is really kind of the point of this presentation, is to bring them to the table and have these ongoing conversations moving forward. But is there a way to consolidate those final treatments and then be able to deliver honest information to the patient and their family that we can consolidate these things into one final fraction? You've gone through this therapy, you have a week left. Can we just combine this into one and then still move forward? I think that may be the direction that I would maybe try to go, although I don't have any personal experience with someone like that.
From a pragmatic perspective, I think that the problem is that in those scenarios, Colleen, those are patients who are receiving either curative or remissive intent therapies almost exclusively. And they're coming into hospice because it's recognized that they're not going to survive despite this particular type of a regimen. I think it's pretty unusual they'd be receiving that sort of a multi-fraction course of therapy that would be strictly palliative and then transition into hospice during that. In almost every circumstance that I've seen like that, it's because they have been, you know, they're at the end of their tumor-directed therapy course. And so the question, as Ryan said, you talk with them, how necessary would this be, and what are the possibilities that these last 2, 3, 4, 5 fractions of therapy are going to make a clinical difference in the patient? You know, so it really is a
The last case I had was a gentleman with a glio, and I think he had been getting, I don't know, several days, like I think maybe 30 treatments total. And like, he very much understood you know, hospice was where he was going to land. And his family understood that too, but his family was like really holding on to, well, like we need to get like these last 4 treatments or we're going to feel like we didn't do everything and we're giving up. So, you know, his main question is like, can I go on hospice? I'm ready to get out of the hospital, but like if my family wants to bring me back for these last 4 treatments, I want to be able to do that, even though he knew the clinical benefit wasn't there, but there was a lot of, you know, just family grieving the fact that there really was not a whole lot more that we could do.
Someone else had some comment. We got cut off there. Additional thoughts? One of the things when you were talking about the need for collaboration and kind of that cross-training, what occurred to me is that we need to have the radiation oncology fellows and the palliative fellows in the same room at the same time, hearing the same lecture. And for both benefits, so that we, as you know, as hospice and palliative physicians, can appreciate what they can bring to the table, but so that they can also understand some of the constraints that we're up against, and and sometimes the clinical scenario of these patients, such that they may not be in a position to be able to withstand or tolerate. And if we're only going for symptom management, then is there some creative ways that we can really adjust? And I don't know, I'm Hickory, do we have a radiation oncology fellowship program in Grand Rapids?
I don't
I'm aware.
think so.
I didn't think so. Just looking, one note in the chat here. Let me just take a quick at this. And just I'm summarizing, Matt, your note that I like that your last sentence. I often wonder if decision making is sometimes selective in nature and not necessarily made with full science in play. I think we sort of addressed that, the fact that there are issues of cultural significance and habit and tradition that sometimes dictate why we as docs do what we do. And just as a peripheral anecdote, you know, when I was in medical school and residency, doing my obstetrics training, because I ended up delivering a lot of babies, every woman got an episiotomy. That's what you did. That's the training, because it's what we did. And it wasn't until some years after that that people started saying, well, where does that really come from? And it came from a textbook somewhere around the turn of the 20th century, in which a doctor really thought that there would be less damage and long-term consequences to the bladder and the perineum if you put an incision in, as opposed to letting it tear. Well, of course, we later found out that you can deliver without tearing, and you know that the consequences of episiotomies and the tearing of creating third and fourth degrees was a much higher risk, and yet that habit continued, probably still continues to this day, despite scientific evidence saying this should not be a routine procedures. Habits die hard. So I get that. Other comments, questions for Ryan? Very well done. Thank you for presenting.
Thanks.